Hello and welcome everyone. Today presentation is on EEG in critical care. This is the first of our series on EEG. We will gradually cover the details of individual EEG presentations and finally the continuous EEG monitoring in ICU. EEG is a key investigation in critical care which helps us in diagnose and prognose the neurological conditions. The common applications are in encephalopathy, where it helps in assessing the brain function, seizure disorders, where it helps in assisting in identifying and managing seizures, hypoxic and traumatic brain injuries to evaluate the brain damage and recovery potential, cerebral structural abnormality aiding in detecting structural issues in the brain, coma, where it provides insight into the brain's state and potential for a recovery. It has got therapeutic usage like in monitoring the depth of anesthesia, non-convulsive seizures to help us in identifying the condition and using effective anticonvulsant therapies for its management. Now, common EEG patterns are a slow wave activity that indicates general brain dysfunction or damage, frontal intermittent rhythmic dentau activity, the FIRDA, associated with various brain disorders, triphasic waves, which are often linked with metabolic or toxic encephalopathies, epileptiform patterns, periodic discharges, which can indicate an ongoing brain disturbance, suppression, which reflects severely reduced brain activity, and burst suppression, which indicates severely impaired brain function, often deep coma. Now, the basic principles are EEG captures the electrical activity of the cerebral neurons as a potential difference between scalp electrodes. The signal processing is done by converting the EEG signals into the digital form for analysis. Amplification boosts these signals typically from 20 to 100 microvolts in a healthy adult. Now the frequency ranges from 0.3 to 70 Hz and filtering helps to reduce the noise and enhance the signal clarity. Waveform display is finally done to explain the morphology and frequency. Alpha activity predominantly seen in the posterior cortical regions. Reactivity to the alpha activity attenuates or blocks with eye opening or mental activity, which means that with arousal, alpha activity is usually gone. Beta activity, it is present over the anterior brain regions. Now there are effect of drugs on the EEG pattern. The sedatives and anesthetics and the anticonvulsants tend to increase the beta activity. Now there is also a progression of depth in anesthesia in terms of EEG patterns. So this corresponds to deeper levels of anesthesia by more slower frequencies. Now various agents have been used, but mostly it is the propofol to which we will see the most specific response. Like in stage 1, there is a decrease in the beta response, increase in the coherent alpha activity, particularly over the posterior head regions. Stage 2 is the emergence of slower and incoherent frequencies. Stage 3 is progression to a burst suppression. And finally, suppression of all cortical activity is called stage 4. Now, epileptiform patterns and sedation. The assessment during sedation is possible but may not be fully reliable because the sedative agents can reduce the epileptiform activities. Now, weaning from sedatives temporarily reduces the sedative requirement, may yield a more accurate EEG for interpreting ongoing background activity. Now, encephalopathy in critical care is a very important topic, and there are very few monitoring that can be done for encephalopathy in critical care, especially the metabolic encephalopathies, which are very difficult to diagnose. Now, the definition is a global cerebral dysfunction, and the commonest causes are metabolic derangements like hepatic or renal. It can be also because of infections, that is septic encephalopathy, toxins, trauma, and hypoxic or hypoglycemic ischemic encephalopathies. Now, all these conditions do not have any specific testing, and they may not be indicative in MRI findings always to pinpoint an exact diagnosis. So mostly these patients remain in a confused state, and also the doctors are unable to make a proper diagnosis as to the reason of the encephalopathy. Now the role of EEG is very important because it is sensitive to measuring the cerebral dysfunctions. It provides insights into the severity of this encephalopathy, and the patterns that we see are in early stages, we see a fall in the alpha rhythm, and in advanced stages, there is slow activity, the triphasic waves, the FIRDA, the PDs, and intermittent suppression, even leading to burst suppression. Now, slow wave activity, it indicates like theta and delta frequency activity. They're present in more than 50% of recording in awake patients. Now, the associated conditions are neuropsychiatric drug usage, structural cerebral abnormalities. Now, the FIRDA, it is characterized by regular bursts of 1.5 to 2.5 hertz over the frontal regions. Now, they are associated with mild to moderate unspecified encephalopathies, metabolic derangements, and cerebrovascular diseases. The triphasic waves, they caused by toxic, metabolic, hypoxic ischemic encephalopathy and prion diseases. They can also be seen in drug overdose like sodium valproate and baclofen. Regarding the periodic discharges, that is PDs, they are uniform waveforms with quantifiable interval. So they are divided into LPDs, BIPDs, and GPDs. Now, clinical context varies and they are often associated with seizures. LPDs are associated with herpes simplex encephalitis and stroke implications. LPDs, that is lateral periodic discharges, occur because of acute lesions like stroke, space occupying lesions, and encephalitis. There is a high likelihood of seizures in these cases. Bilateral independent periodic discharges, that is BIPDs, they are due to hypoxic ischemic encephalopathy, hypoglycemia, encephalitis meningitis, or herpes simplex infection. The prognosis is often poor and frequently associated with seizures. Finally, we have the GPDs, that is generalized periodic discharges. They are seen in toxic, metabolic, and hypoxic ischemic encephalopathies. The management is a focus on the underlying disease, and presence of this is a poor prognostic factor. Finally, we have the stimulus-induced rhythmic periodic or ictal discharges. Now, they are seen in comatose patients in response to stimuli. The clinical significance is uncertain, but the prognosis is usually poor and difficult to distinguish between an ictal and a non-ictal activity. Next is suppression. These are low amplitude EEGs with voltage under 10 microvolt across all channels. The indications is anesthesia, that is a deeper state of anesthesia, which is usually reversible. In pathological condition, it is severe brain dysfunction, which is often poor prognosis. Possible causes of this are cerebral intoxication, post-ictal suppression, brainstem hemorrhage, cerebral ischemic edema. Next is electrocerebral inactivity. This is extreme suppression of electrical activity within the 2 microvolts. The cause is profound hypothermia or hypotension or the use of CNS depression drugs. Irreversible coma in ECI should be considered only when you have excluded all the reversible causes. Finally, the burst suppression. Alternating sharp and slow wave activity bursts with period of attenuation and suppression below 10 microvolts. The diagnostic criteria is 50% of the EEG consists of attenuation or suppression. Periods of electrical activity alternating with isoelectric or electric silence indicate unconsciousness and profound brain inactivity. The commonly due to sedative or general anesthetic agents, which is again reversible, but more dangerously it can be because of status epilepticus, hypoxic ischemic encephalopathy, where the prognosis is poor. The clinical management is to hold the sedation if the patient is on a sedation, and in pathological cases it is the treatment of the underlying cause. In the context of myoclonic status epilepticus and post-hypoxic injury, the presence of this is a poor prognostic marker. Finally, EEG is epileptic form disorders where it is more commonly used, and the most common condition where it is used in the ICU is the non-convulsive seizures. Now, essential in patients with disordered consciousness, coma, history of epilepsy, post-neurosurgery, stroke or cerebral infection. Vigilance is needed for convulsive status epilepticus and in hypoxic ischemic encephalopathy. The diagnostic criteria is repetitive epileptic from discharge, that is frequency more than 2.5 Hz for more than 10 seconds, that is non-convulsive seizures, or if it is status, then it has to be for more than 30 minutes. Now, other patterns are frequency less than 2.5 with rhythm of more than 0.5 Hz may indicate either non-convulsive or non-convulsive status if accompanied with spatiotemporal EEG evolution or clinical and EEG improvement after anticonvulsant therapy. The treatment is individualized due to the risk benefit to be considered. Continuous EEG monitoring is to be done for cerebral activity along with clinical behavior lasting from hours to weeks. The applications are in non-convulsive status or status epilepticus, guiding the anesthesia depth in refractory status epilepticus because we want a burst suppression as a marker of our clinical endpoint. Distinguishing non-epileptic from events mimicking seizures, detecting real-time changes in brain function, cerebral ischemia with subarachnoid hemorrhage. Recommendations by the American Clinical Neurophysiological Society and European Society of Intensive Care with proposed usage of continuous EEG is to be done in non-convulsive status. Still, it is an active area of research which requires more resources and expert interpretation. Challenges are it needs more evidence for definitive assessment, requires dedicated equipment and real-time expert analysis. Expert interpretation may not always be readily available in all clinical scenarios. Regarding prognostication in coma with EEG and SSEPs, coma definition is an eye-closed state of unresponsiveness with severely impaired arousal and cognition. What is the EEG in coma? The assessment is to identify reversible causes like intoxication with sedatives or non-convulsive status or status epilepticus. Now, neuroprognostication can be done here in case of cardiopulmonary arrest or traumatic brain injury. Outcomes are favorable if there is continuous rhythmic activity reacting relative to alternating stimulus. Unfavorable outcome is non-reactivity, discontinuous and suppressed EEG, presence of epileptic from discharge, and generalized periodic discharges. Now, reactivity in EEG means EEG change in response to an external stimulus manifesting as a change in the amplitude, frequency, or both. It is not precisely quantified yet because we don't know what its quantification is to be like. Now, regarding the SSEPs, it is the electrical activity from the peripheral and central sensory neurons and electrical stimulus of the median nerve at the wrist response is recorded at various points. Key components for prognosis is upward deflection generated in the primary sensory cortex, that is called the N20 response. Artifact reduction is by computing the average of responses to eliminate the background noise. The neuroprognostication in SSEPs is bilateral absence of N20, indicating an unfavorable prognosis in hypoxic ischemic encephalopathy. The presence of N20, the prognosis is indeterminate in hypoxic ischemic encephalopathy, but more favorable in traumatic brain injuries. Now, timing, SSEPs are more reliable after 24 hours of post-cardiac arrest or light sedation and normothermic conditions. The conclusion is EEG provides a real-time objective measure of cerebral activity, informing diagnosis and management, especially the neurological examination is challenging. As in ICU, most patients will be on ventilator, intubated, sedated because of the low GCS. Measuring the brain activity becomes a very important factor, and GCS is not a major or effective tool to monitor the brain activity. Thus, the role of EEG is paramount in ICU setups. Now, complementing to the neuroimaging is the main factor because EEG can help to be interpreted alongside the neuroimaging. So in future classes, we will be discussing in more details about individual waveforms and individual conditions, how to interpret them, how to use them in our ICUs. Thank you.